Hi, over here we are with me. There's Dr. Swami, Dr. Vanna, and Sanjeev. Hi, Swami. Swami is an eminent scientist working in this space, so we'll discuss further. And Dr. Vanna is a clinician working in the longevity space. And then Sanjeev is there for the technology part, the medtech part, what is happening over here. So, we all over here, we understand that longevity is about eat right, move right, sleep right, that is something. So exactly what we are doing is, can we know the numbers for all these three? And what to measure, how to act is the game. So good afternoon everyone and welcome the panelists. So over here, what we are going to turn around in next 30 minutes is, can we create something that we know where we are already and what next is coming in the science to take it forward. We all know that it is not something that we are short on what we can measure. There are so many things, there are so many markers which are coming, but what fills in at the right level, whether it's the adoption part which is lacking, or is it that what is specific to India per se. So we'll deep dive with all the panelists, three different lenses. One is the clinician lens, one is what is brewing up in the medical side and the biology part, what is the kidney or their new biomarkers on which Dr. Swami is working, and what all is coming from the medtech, on the gate, say on the ingestible devices, and so on. So let's start with the real actionable one now. So let's start it that way. If there's a person walks to you, a 40 years of age, and wants to know how to work around its longevity or health span journey. So how would you like to start that?
First of all, thanks Prashant for having me as part of this panel, and thanks to RISE organizers, Deepak and the team for having me here. It has been, of course, an amazing initiative by the team. Now coming to Prashant's question, I will answer this question, Prashant, from a clinician's lens. We've been hearing a lot of researchers who are doing amazing work, and I'm sure their answers will differ from my answers. But if a young 40-year-old walks to me, I'd like to do certain tests and like to sort of classify the cardiometabolic tests, the functional tests, the vitamin and mineral deficiencies, and then certain gender-specific tests that I like to do. So in the cardiometabolic tests, very important tests that I like to do would be ApoB, LPA, HSCRP, blood pressure measurements, fasting insulin, and HbA1c. But with HbA1c, I like to classify that. I'd like to understand the serum ferritin and the hemoglobin levels, as it can get falsely affected by some of these levels. Then when it comes to the functional parameters, VO2 max, if that is accessible, is a very important parameter that I like to understand. Grip strength, very easy to measure, weight measurement, the waist measurements, the height to waist measurements. If possible, then HRV as well, and the resting heart rate. On the vitamin deficiencies, now this is something very specific for India. I'd like to understand serum B12 and folate levels, but I'd like to classify here that I would also like to understand homocysteine levels along with that, because the B12 assays sometimes do not give us the exact active form of B12 which is available, and hence sometimes homocysteine is a better marker of B12 deficiency rather than B12 measurements itself. I'd like to understand especially given in women, the iron studies, because a lot of times we try to treat iron deficiency only on the basis of hemoglobin levels, but we all know that's not exactly the way to treat it. So proper iron studies, especially serum ferritin, is something that I'd like to do. And vitamin D deficiency, which is also very common in India. So these are on the vitamin and the mineral panels that I'd like to understand. And then when it comes to a gender specific, I think very important, more than the testing, I'd first like to understand if women had been pregnant and if there is any pregnancy specific biomarkers, which means that, for example, if the women had gestational diabetes, or if there was a preeclampsia history, or if the women had any kind of intrauterine growth retardation, etc. Because this will help me reclassify the risk for that woman. I'd also like to, since it's a 40-year-old woman, probably perimenopausal already, I'd also like to classify the cycle length and put them into the criteria of the Strauss staging. And then for women, I'd also want to understand the thyroid functions, which is your serum TSH, free T4, and TPO antibodies. and a DEXA scan, because that's the age when probably some changes would start in a woman's body. Of course, a man's body as well, but definitely for a woman, to understand the lean mass, especially the appendicular lean mass, the visceral fat, and the bone mineral density. And then, of course, the general parameters like your liver function tests, where I would specifically want to understand the FIB4. So I would want to do those tests. And then the kidney function tests, where I'd like to understand the eGFR. And since Indians sometimes have less lean muscle mass, I think there I'd like to classify if eGFR is not something that I'm very focused on. I would also like to do cystatin to see which one would give me a better indicator of the eGFR. And then other than that, rest of the things like your BMI, which is not very accurate, but still I think for tracking BMI measurements could be good.
So great. I think what Vandana has clearly stated, that we have to look wholesome towards the patient. It's not just one part. We understand that there's something called as in the lipid metabolism, where probably lipid profile is something we all do. Is ApoB and homocysteine are the next way to go? Or we are looking at inflammatory markers other than HSCRP, or we are going deeper on metabolic, just not the insulin levels or HbA1c, or we going to HOMA-IRs, etc. And then there is a whole new array of tests which are being developed, over which we'll be talking over the period of time, whether that is cystatin C, or there are many more kidney markers which are coming up. So just taking the discussion to the next level, Dr. Swami, if you can just take me to the kidney and aging relationship.
Yeah, thank you, Dr. Prashant, and nice to meet all the panelists here. Thank you, Dr. Deepak, for this opportunity. So the role of kidney in aging is really unraveling as we start having more discoveries. So let me start with one of the first observations that we know for the last decade or so. There is a particular hormone called clotho. It's actually made by the kidney, and it circulates in the blood as a hormone. And it's the only known anti-aging hormone that has been described. And it regulates fibroblast growth factor 23 signaling, and there is a connection with the phosphate. And in fact, if more dietary phosphate has been linked to accelerated aging as well. So that's a very interesting thing that's primarily regulated by the kidney, a direct connection. Now, second fascinating discovery that was published in Cell within the last year, where they looked at how does exercise mitigate aging. And then when they looked at, it turns out a small chemical called betaine seems to be very important for inhibiting the inflammation and reducing the aging phenotype. And when they looked at where it is coming from, exercise increases betaine synthesis in the kidney, and kidney then dumps it to the system to retard aging. So there is a second connection we are seeing in addition to clotho, where a betaine coming through the kidney retards aging. Now the third very important thing is the link between salt and aging. There are numerous studies that have looked at, sodium, how it can cause accelerated aging of the immune system. The primary regulator of sodium balance in the body is the kidney. So again, you can link that. And two other things I'll mention, and then I'll stop. The fourth important aspect to aging is the renin-angiotensin-aldosterone system. And renin is actually made in the kidney by the juxtaglomerular cells. So this renin-angiotensin system acts across various organs, including the immune system. And the fifth one is the vitamin D. And vitamin D, to be converted to 125 dihydroxyvitamin D, that activation happens in the proximal tubules of the kidney. So again, vitamin D and its effect on the inflammatory system is largely regulated by the kidney as well. And then on the top, you add the oxygen delivery and hypoxia being an important thing. The primary hormone which regulates red blood cell production, again, comes from the kidney. So we don't know why so many key factors related to aging is all concentrated on the kidney, but it seems like it's probably the most important organ, which is kind of neglected, to a large extent, could have a very important role in how we age.
So yeah, beautifully put. So we all understand that EGFRs and cystatin C are already established markers, but only the adoption part is pending. Then there are few markers which you are talking of, about clotho and betaine. Just going a bit deep, can you just elaborate, are we there that we can measure them or we can supplement them related to, can we work on their pathways? Where is the science right now?
So those are good questions. So before I comment on the supplementation, I want to add a very important point here. Like our panelists mentioned, there is a huge discrepancy the way you measure kidney filtration with creatinine versus going with cystatin C, particularly in population where the muscle mass is less, where creatinine comes from. So we recently had a paper that we published where we are showing that there is about 10-15 ml difference in estimated GFR in Indian population in eGFR measured with the creatinine versus cystatin C. So this is a very important consideration. In fact, there is a paper in Nature in 2023 looking at organ aging. And again, the difference between the eGFR measured by creatinine and cystatin C can give you an indicator of what's happening to your body. So now coming to the measurements, clotho can be easily measured. There are many simple assays that are available like ELISAs or other things. You can measure it in the blood, you can measure it in the urine as well. And there are companies, something called Clotho Therapeutics. They're coming up with, really taking it to the next level. And I think people are working in those directions. Betaine supplementation is easy. And one last point I want to add is, there is a concept of immunoaging, which is the thymus. And clotho, when it is low, because your kidney function is low, it leads to involution of your thymus gland, meaning like your thymus, which is the primary immune organ, shrinks. And it turns out that thymus makes another anti-aging hormone called thymolin, which has just been described recently. So all these are connected. You know, how the immune system and the kidney and dietary intake of zinc. Zinc binds to thymolin to make it beneficial. So nutrient intake is so crucial here. So if you limit phosphorus, take more zinc, all that can be beneficial.
Yeah. So what we are talking of, the framework we know, what we are measuring is the output protein of inflammaging. What is happening behind? Can we go to the proteins one level down, like clotho or thymolin? So as over what science we know up till now, the thymus plays its role by the time you get adolescence. And what we are knowing right now is that it's still prescribing how your aging will run. So good to know. So, and a long way to go. Switching from what we have developed on the biology side, going to the technology side, Sanjeev. So, as I know, Sanjeev, you have worked a lot in this area, and there's so much of it from the physical parameters, like things are evolving from BMI to gait. Now, gait is practically a 6th level marker in the whole aging thing. So, gait, then your grip strength, and now the things are about ingestible device. So how do you look at this? What all we can add from the medtech side on this non-blood biomarker measurement of the very basic thing, eat well, sleep well, and move well. So move well is a part of yours.
So thank you. So I'm an electrical engineer who stumbled into this very interesting field. Okay, so I'm by no means an expert in this. But I just got interested and I spoke to a lot of people. So if you want to call it a customer discovery. And the first few things I learned is, so if I may address my customers as geriatrics, I spoke to an aging population. The first few things I learned is they do not like technology. That's the first. The most valuable things are they want to be independent, respected, and be valued members. So these are the top priorities. So these become an engineering constraint. So any engineering product or device that you develop should sort of meet these social constraints, if you would like to call it. And then when you look at the core problems faced by an aging population, 3 of them came out. The first is, the most drastic one is fall, because fall is a very critical point, because after that, it's just a way down. But then when I looked at what's being done about fall, there are plenty of companies, organizations, and ideas looking at fall detection and fall prevention as well. But I also interestingly noted that many of these do not meet those social constraints. So just to give you an example, I saw a Japanese product wherein they allow the geriatric to wear a tail. And just like how animals balance out by having an extra limb, if you would like to call it that. But this does not meet that social constraint, which I just pointed out. The other one is in muscle development, because this is the cause of all falls, right? So muscle development, as if you would like to call it physiotherapy in general. So is there something interesting you could do in the physiotherapy space? And the third one, which I've personally taken a very great interest in, is in trying to identify problems before they crop up. And I would like to broadly classify this as ingestible electronics, because that is the easiest access into the gut. And the idea there is the problem that I'm working on, and I will then talk about what's going on around in the world, is just like you have a cough drop, right, which you can go off the shelf and purchase it off the shelf. Can we have a capsule which has sensors inside it, which has got electronics inside, and the aging person or the geriatric, if you would consume this capsule once every month, all right? And this capsule would detect something of clinical importance in the GI tract and then radio this message to the outside world, maybe to a necklace or to a belt, and then be digested by the body. So essentially, you're building electronics that is completely digestible. And this is a problem that I have personally taken an interest towards, because it is completely safe. A child should be able to swallow it just for entertainment without any harm. And at the same time, it's valuable. And the purpose of this capsule is to not give out detailed information. We do not need to know the exact concentrations of various proteins or analytes, but it is to get a signature of what the general gut health of this person is. And then when this goes off track, or when this crosses a certain threshold, it just sends out a warning saying that it's time to go see a doctor. So it's a very preventive, approach. And when you look around, you see that there are many people trying to do something similar. A very good example is a capsule called as Gizmo, which looks at oxygen reduction potential in the GI tract. And I think this is developed by Caltech, if I'm not mistaken. But then it's not digestible. I mean, it is a capsule, it's got great value. You need to go to a clinician, and the clinician will give you this dose of this capsule. And it looks at basically the pH balance, the electrochemistry going on in the gut. And this is valuable information. And there's plenty such, problems being solved. But always, I would like to keep this social constraint that I've discovered. And this fits within that. The technology is there, but it's hidden. The user is not exposed to the technology. And at the same time, it does not, bring about any, any upsets in the social standing of that individual. Okay, so this is the broad answer to this question.
Yeah, very right. See, we all understand, we are working in the academia or intelligentsia part of it. So there is a journey of science from creation to adoption. And science in isolation at times comes with a solution which may not be that practical, like a tail. So exactly what we got is that we are moving from implants to ingestible devices, what you're talking of. So we have done a lot of work as a science on implantable devices, where sugar, different measurements, you are getting a real-time measurement, and now you can act on that. And now we are talking of ingestible devices, which can give a personalized understanding. See, we all understand that ultimately there are biomolecules which are being secreted by the body for the whole continuum of information. But we don't know the reference ranges, neither we know how to manage it or report it. Like everyone knows that cortisol is such an important thing. But measuring cortisol and putting the right level is still not clear. We all know that stress affects longevity. But can we have a continuum monitoring of cortisol, and can we have a bioreferences for a person measuring that cortisol? I think those are the answers which lies with technologies like ingestible devices or some devices where we can take it. So to start, so now we have 3 different lenses of the same problem, what we can measure and what we can bring to action. We'll take these last 5 minutes to build something concrete to take home for the room. So we'll come to each of you. How do you look at it? What would be the measurable science for this longevity journey in coming, say, next decade? So starting with you, Vanna, how do you look at it? And then we'll move forward.
So I think if I see from a clinician's lens, Prashant, I think there are, obviously longevity as a science is advancing a lot, but there are very basics which have not yet percolated into the clinical world. From a scientist, from a clinician's lens, I feel that some of these basic tests which I just mentioned, one, they need to be definitely implemented across the country. They need to be more widely available. Today, we still call, for example, LPA and ApoB as advanced cardiac markers. I don't understand what is advanced about them anymore. And because they are called the advanced cardiac markers, a lot of patients think that I don't need it, I am healthy, I don't need the advanced cardiac markers. I think it's time we start implementing some of these tests at the mass scale, especially at the age of 40, because we need to understand two things here. One, this is a time, that's the age when body is going to undergo certain changes. And given that we are South Asian phenotype, genotype, there are a lot of diseases which tend to develop much earlier in Indians. And some of those diseases could be almost a decade earlier compared to the Caucasians, right? So we definitely need to start measuring definitely by something like a 40, right? That's number one. Number two, the reference ranges is something I think all of you are here, and I'm sure a lot of work is going on right now to understand what kind of reference ranges we should be extrapolating from all the blood reports that we get as clinicians. And this is something which we still don't have a good clarity on, as you rightly mentioned, that we don't know the reference ranges. And thirdly, I think there needs to be definitely some more action that needs to happen on gender-specific work. A 40-year-old woman is not the same as a 40-year-old man, right? And I think that's why there is a lot more desirable when it comes to women who's 40-year-old versus a man who's 40-year-old.
Yeah, very rightly said. So we are very, very clear as a science, it established but needs to be practiced that ApoB, LPA, homocysteine, these are the markers which vary a lot. Two people having same LDL values may have a different mortality risk when it comes to when we see that ApoB, LPA and homocysteine, and that has been proven by so many studies. So a very important thing. And that phenotype part is also a very, very important point, that there are studies which have come that in Indian phenotype, even at 25 BMI, you get a visceral fat of 33% or very high insulin resistance is there. 1/3 of our population with BMI 25 is having insulin resistance in India. So that BMI phenotype thing has to be taken off, and we should go deep, measure right thing. That is the first key takeaway I'll take from Anna. And coming to you, Dr. Swami.
So I think a lot more science need to be done in understanding the process of aging. And as pointed out, there could be population-specific differences. And we have got, like Dr. Brittati presented, we have got so many ethnic phenotypes in the population here, and their exposome is very different across the country. So if you really go and sample them and get all those phenotypes, we may get extraordinary clues. And these clues could be very specific to the individual population. For example, a marker or markers or pathways of aging in a Dravidian southern India population may be very different than what we are going to see in northeast India or the northernmost part of the country. So there is a huge scope for research and discovery right around this. So that's point number one I want to mention. The second thing, when I look at the literature, aging is from multiple factors that's happening simultaneously at the same time. For example, we have a metabolic phenotype in Asian, but we are simultaneously exposed to heat, from the global warming, and also to pollution, and all the things are happening at the same time. So how does this really accelerate aging process? Are there things that we need to understand unique to this population? So those questions need to be answered. The second comment I want to make is any diagnostics or anything we are going to come which is going to predict aging unique to that population, it's likely to be multiple novel things integrated together. For example, looking at immune system, looking at kidney, which we discussed, and various other components like cognition and so on. And it has to be made scalable, and it has to be made affordable to be able to reach very large populations in the country. So that's something here as well as the world, that's something we need to keep in mind. The third thing I want to comment is magical interventions are always exciting, but sometimes we need to think about simple interventions that could benefit population at scale. See, for example, there is a lot of emerging data in vitamin C in certain forms, not as a pill, but in certain forms may have an inhibitory effect on lipid peroxidation, aging process, and so on and so forth. So there may be some clues which is hiding in the plain sight, which we need to look into to kind of take it and give a scientific flavor to it so we can scale it up.
Yeah, so Dr. Swami very clearly said that we have to understand the ethnic part and the environmental part. Coming from Delhi, I am really, that fear we all are dwelling on what pollution will have on this whole longevity thing. So yes, it is very, very important to understand the genetic makeup. Like day in and day out, we are seeing that in India, we are getting a very high homocysteine level, which is not so published everywhere. Healthy individuals, 30% of healthy individuals are getting high homocysteine. So MTHFR mutation is something which we are dwelling in, and we don't know how it is affecting. So deeper studies, deeper hallmarks are to be done. And similar things on environmental thing. As Northeast, we understand there is a totally different clinical profile of oncology and everything when it comes to Northeast, simply because the Oriental population and all, they have a different gene set and a different food habits. So probably they are not having a shortage of things which are coming from redox reaction, like they have a very high omega-3 fatty acids. But again, then smoky food bringing different oncology layer, so different diagnostics and preventive layer has to be put on. Now going to the medtech part. Sanjeev, if you can just put a few words over there.
Sure. Okay, so I largely believe preventive action is the best approach. And this should start much earlier. As Dr. Vandana mentioned, maybe age of 40 is probably a time where, this kind of involvement of the person, the technology can begin. Right now, I don't know, I'm speaking with wearing an engineering hat, so I don't know whether that's biased.
You are the guys who are going to make it at the end of the day.
That might be biased, but the reason is I think personalization is very important. Everybody's signature is very different. So I think the medicine or the treatment or the exercise that you're going to develop has to be personal. And for that, it requires a lot of data gathering. The machine or the engineering has to understand the person or the individual. And therefore, this needs to begin at a very early stage when the individual is healthy. So you start marking the health signature. And that's when I think signs, the negative signs that come in when aging begins, can be highlighted and picked on much earlier. So that's my only take.
Yeah, very rightly put. And right now we are struggling over there as a medical science. Our reference ranges have a 3 times variation, like vitamin B12, normal value goes from 211 to 900. So what is the normal for which body is something which is still to be done, and to take it to next level. The CV variations right now which we are working are on the tune of 20%, and I think we have to make it more scientific and more engineered rather from medical side to that part has to go more binary. So I think that is what from the panel. These are the things which we can discuss for the whole day. But taking the time constraint, we can move to any questions and any discussion further.